This morning, we're delighted once again to have Dr. Theophilus Asumu with us. He was with us a few weeks ago, and you know, we had so many questions for him that he dedicated 2 days in a row. So just going to get our Zoom live now, and we will
come to CAHN's Health Hour.
Great. So, Doc, over to you for the presentation, and then we will get into Q&A.
Okay, so I'll start off by, I'll go straight into the presentation and try to share my screen. If you give me about a minute or so. Right, okay, can you see this? Am I successfully sharing?
Yes, Doc.
Right, okay. So once again, just by means of introduction, I'm going to spend about 20 minutes talking about trauma and orthopedic surgery, giving a brief overview of what the specialty involves. My name is Theophilus Asumu. I'm a consultant orthopedic surgeon, and I work out of a group of hospitals in the northeast sector of Manchester. I've been a consultant there now for about 20 years, but by background, I'm Nigerian, and my medical training was in Nigeria before I came over to the UK for specialty training in orthopedics. So what I'm going to try to do is to give an overview of what trauma and orthopedic surgery involves. And that really is dealing with problems affecting the musculoskeletal system. That is the bits that make us move, the bones and the joints. It's mainly your hips, knees, ankles, shoulders, elbows, wrists and hands, your back and your neck. We deal with two different categories of patients. One are those patients who sustained an injury, and those who are referred to us having pain, generally arthritis, some type of arthritis. The most common of which is arthritis, where you get pain and limitation of movement, limitation of day-to-day activity. Another area which we've talked about previously is osteoporosis, which really is not a condition that causes any pain, but places you at increased risk of breaking a bone or sustaining a fracture. And I think that's quite relevant to the Caribbean and African population in the UK. For today, I've focused previously on other aspects, and I'm happy to take any questions regarding hips, knees, ankles, feet, backs, etc. But my presentation will be focused today on problems affecting the feet. But don't feel constrained by this. This is just some information dissemination, and your questions can relate to the wider generality of bone and joint problems. So in terms of why musculoskeletal problems as they present to a trauma and orthopedic surgeon in the context of the UK is important is that it's actually quite common. And about 14% of all GP consultations will relate to a musculoskeletal complaints. If you do a survey, about 15 million people in the UK at any point in time will tell you that they have a problem with a bone and or joint. The vast majority of that being back and neck problems. Back pain is incredibly common, and about a third of them have moderate or greater arthritis. And in terms of osteoporosis, you've got about 3 million people who have osteoporosis. So it's quite a common problem. When you do have musculoskeletal pain, it impacts your life, and it especially impacts your working life. So if you take a look at people who are unemployed and who have long-term conditions, you find out about a third of people who have long-term musculoskeletal pain are not able to work. And of those who work, if you look at when people take time off work or they report problems with their work, 40% of those are related to musculoskeletal problems. And the only other category which gives you as much problems as work is stress, anxiety, and depression. And those are two big things, which there's some degree of interplay between both of them. In terms of ability to work, the only other category that makes you less able to work is mental health problems or learning difficulties. So we can see the effect that having musculoskeletal problems has. In terms of who suffers from musculoskeletal pain, it is largely a problem that gets worse as you get older. And that's down to aging of joints, arthritis. And so there's a steady rise through life, and you do get a slight increase in incidence in women. Not terribly significant, but more women do have musculoskeletal problems than men do. So I'm going the wrong way. So if we take a look at the fact that we're dealing with an older population by and large, most patients who attend my clinic, most patients who I'm operating on are elderly. They're above the age of 65. How does that translate to Black and African population in the UK? Well, the Black and African population in the UK is a recent migrant population by and large. And so the distribution of the age of African and Caribbean people in the UK tends to follow a different pattern from the overall population in the UK. So I take a population pyramid here from Nigeria, which is where I come from, population of just over 200 million. And you have a standard classic population pyramid where most of the people are above the age, so below the age of 30, and very few people above the age of 65. If we compare that to what we find in the UK, population just under 70 million, a much larger proportion of the population is above the age of 65. And this has an impact on the patients who you will see complain of musculoskeletal pain. So we've looked into this a little bit further and looked at ethnic minority populations in England and Wales, and the findings from the last census, which was in 2011. Another census is due in 2021. It takes place every 10 years. And you find that as a rule, ethnic minorities, especially Blacks and Africans, tend to be younger than the indigenous population as a whole. And so, for instance, for the African population, the percentage of people above the age of 65 is less than 3%. So very small number of very elderly people. For the indigenous population, it's about 18%. There's a difference between the population distribution of Africans and Caribbeans because of a longer migration patterns for the Caribbeans. And the Caribbean population distribution is closer to that of the indigenous white population than the African population distribution. So the conclusions from those observations is that ethnic minority populations in the UK are younger than the majority white British population. Because of that, they use less of the health and care services, apart from maternity, where, of course, where women are in their childbearing years, they tend to use the maternity services at the same level. I think the other thing is that the use of a maternity service is not optional. The use of many other health services, you may choose to engage if you've got back pain or knee pain, but if you're pregnant, I don't think you have any choice but to have maternity services. But the situation is going to change as the populations age. And the question is how people will engage with the health services as they start to require these services, which are there. So, sorry, right, I'll go ahead. So, ethnic minorities in terms of musculoskeletal pain, in terms of pain affecting their bones and joints, they differ from the indigenous population. And not only do they differ from the indigenous population, they differ from the population of their originating country. And there are a whole host of factors that come into play when people present with musculoskeletal pain and how willing they are to engage with the health services, including previous health beliefs from your country of origin, including your culture, your socioeconomic class. Is there a systemic bias within the health service, which, for instance, means that if English is not your first language, you don't get access to health information leaflets, which you can understand, language barriers. And another big thing is vitamin D levels, because we know that black skin doesn't make as much vitamin D, black and brown skin, as does Caucasian skin. And so there's a much higher incidence of vitamin D deficiency in Black, African and Caribbean people in the UK. I think this is a big area where we see that there are health inequalities. And I've put CAHN's, the Caribbean and African Health Network, I've put your logo up there because I think it's an area where you can help as things start to move and the population starts to age. How do we ensure that Africans and Caribbeans have the same access to the very good healthcare that's available in the National Health Service? So I'll just put it out there for you guys. So in terms of foot pain, it's quite common. Nearly 1 in 5 people will have some kind of problem with their feet. We know that females tend to have slightly more problems with their feet. If you're obese, you also tend to have more problems. But also if you play a lot of sports, and that's just down to use. Older people tend to have more problems with their feet. And if you have pain elsewhere, if you've got pain in your hips, knees, shoulders, back, you're more likely to have foot pain. And it does form a significant proportion of consultations in the health service, especially in primary care. So some common foot conditions are illustrated here. The treatments are largely uniform. And I've listed what the vast majority of the treatment here is. I think a lot of people will be happy to know that surgery is not required in the vast majority of patients who have foot pain. And I mentioned that because I think there's increasing evidence coming out that Black and African people tend not to like surgery as a form of treatment, or at least tend not to avail themselves of surgery as much as the indigenous population. And we've looked at things like hip replacements, knee replacements. The number of ethnic minorities getting these operations is much smaller than you'd expect compared to their numbers in the population. So the most important thing I think with foot pain is you look at the type of shoes you're wearing. That is key. If you're wearing decent type shoes, then there are other things that can be done, such as insets, arch supports. We call those orthotics. And those can be provided by a podiatrist. You can get some off the shelf, but the made-to-measure ones, which are designed for your foot, are probably better. There's a place for chiropodists and a physiotherapist. And occasionally you might need an injection somewhere in the foot. And a small percentage of patients, I said, require surgery. But it is a small percentage of patients. And the vast majority can be managed by this multidisciplinary approach without recourse to surgery. So that's one of the most common foot problems we see. that's a bunion. And I think most people will recognize someone who has a bunion, or perhaps you have a bunion yourself. There's a large amount of heredity involved in developing a bunion. And so people do tend to be predisposed to getting bunions. Slightly higher incidence in African populations. There's a linkage with the type of shoes you wear and your feet almost starting to resemble your shoes. It's commoner in ladies for, I think, obvious reasons. Ladies' shoes do tend to be rather unforgiving, and they tend not to be shaped like the foot in the vast majority of cases. And it's difficult to balance the needs of society, fashion, the workplace with what is best for your shoe. But if you're cramming your toes into a very narrow type of shoe, then you do worsen the problem if you do have a pre-existing predisposition. So it's something important to think about. If you do have a bunion, then a podiatrist will be able to help you for the vast majority of the time. It could be related to things like flat feet, where you can have an arch support, which will help the problem. You can use toe separators like you can see on the images on the right. And if all these don't provide a satisfactory outcome, then in selected patients, surgery is offered. Surgery has to be taken in its, you've got to consider surgery properly. What you're doing is you're trying to reshape the foot to fit the shoe rather than get a shoe that fits the foot. And in some cases, it is definitely required, but that's after discussion with the surgeon. It does take a while to recover from surgery, and this is an example of someone who's had corrective surgery where the bone has to be broken and realigned, and a metal plate or metal screws used to hold the bones in place to enable healing. And so that's one way of addressing the problem. But please pay attention to your footwear first of all. Now, if you go just under the toes, the ball of the foot, that's a common area where you can have pain. And a general term for pain in the front of the foot in this region is metatarsalgia. And that just means pain around the metatarsals. It doesn't imply a specific diagnosis, but just describes the problem. There's an arch at the front of your foot in that area, which goes from the base of the big toe to the base of the little toe. So the big toe and the little toe are supposed to make contact with the floor, and the middle toes are supposed to be slightly lifted off the floor, not the toes themselves, but the metatarsals behind them. If that arch collapses, then you start to get pressure from the metatarsal heads on the sole of the foot. And the clinical picture you can see of the foot at the bottom right of the screen is one such person who has collapsed arch, and you can see the thickened skin beneath the metatarsal heads, the second and third metatarsal heads. And that's a typical picture we see in somebody who has a collapsed transverse arch. And an arch support in this situation would help and take the pressure of the metatarsals off the sole of the foot. At times you find pain in the same area and there's no callus, there's no collapsed arch. And in that case, you have to think of something like a neuroma, and that's quite common. It's an entrapment of the nerve between two of the metatarsal heads, and that's usually, it responds quite well to physiotherapy and an injection. Occasionally, you need surgery to take the nerve out. And another problem you can get in that area is a stress fracture. A stress fracture would normally happen around the top of the metatarsal, usually the second or the third metatarsal. And a stress fracture comes It happens when you suddenly increase the amount of activity you normally do. And so if you take up running, and it's quite common in military recruits actually, who do a lot of forced marching. And so your body isn't quite used to the amount of activity that you're putting it through. So if you're starting a new exercise program, it's probably better to go in slowly and just increase your activity stepwise and allow your body to adapt to the new demands you're putting on it. The treatment of a stress fracture is usually fairly straightforward. Decrease the activity, allow the stress fracture to heal, and then go back to the activity, but go back in a slow fashion. It takes about 3 or 4 months, though, of activity. Flat feet are quite common. Flat feet are very common in children. And as they get towards the age of 10, going through puberty, many of them resolve. Some of them remain flat-footed. That generally doesn't cause a problem. It's something we'll call a flexible flat foot, and it doesn't cause a problem. They are more prone to foot strain, and so you need to ensure that you're using shoes that are properly supportive or put an arch supporting the foot. But there's another category of flat foot, which happens later on in life, usually above the age of 50. And that happens in somebody who normally had a normal foot arch. And I'm showing the examples in the clinical pictures. And where the arches start to drop, that's usually because the tendon has started to stretch out and is about to snap. These are the ones that should be seen by a GP, treated by a podiatrist or an orthotist to give support to that arch and to protect the tendon. If the tendon snaps and there are ongoing problems, it can be corrected by surgery. But if you do notice that your arches are starting to fall, either on one side or both, you probably need to see your general practitioner at an earlier stage. The last condition I'm going to talk about is pain in the heel. The commonest cause of pain in the heel is plantar fasciitis, and I think that's the term that many people are familiar with and are comfortable with. So pain in the heel can be either above the heel, around the Achilles tendon, which is Achilles tendonitis, or below the heel when you... So people with plantar fasciitis will tell you that when they get out of bed in the morning, the first few footsteps are very painful. And they can very easily localize the pain on the sole of the heel. And plantar fasciitis is a very uncomfortable condition, but is eminently treatable with a combination of physiotherapy and stretching out the plantar fascia. Once again, attention to the type of shoes you're wearing, which may be causing things to contract. And in certain cases, an injection. Very, 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 very rarely do you need an operation. Less than 1 in 50 will come to surgery. Achilles tendonitis, we often avoid operating on it. It's physiotherapy, activity modification, and taking some stress off the Achilles tendon. Other foot problems which are out there: toe deformities, hammer toe and claw toes, ingrowing toenails, arthritis, sprains of the ankle. Those are the more common ones which I haven't gone into. But if any of these are a particular problem, I'll pick those up in the question and answer session. Diabetes is one thing I must mention because, first of all, being Black is a risk factor for type 2 diabetes. We tend to get type 2 diabetes much earlier than Caucasian people. From about the age of 25, we start being at risk for some reason, when normally type 2 diabetes starts at the age of about 40 to be a risk factor. And so if you go into any diabetes risk factor scoring template on the internet and do a risk score for yourself, ethnicity gives you many points towards the risk of getting diabetes if you're non-Caucasian. diabetics will have problems with their nerves and their blood vessels, especially if it's uncontrolled. So if you're walking on your feet all day and you don't have as much sensation as you should do, then you're likely to sustain injury without realizing you've injured yourself. And when you injure yourself, because the blood supply isn't quite as good, you're much more likely to get an infection as a result of that injury. And so it's extremely important for diabetics to look at their feet every day, ensure that they have proper foot hygiene, and ensure that the shoes they're wearing do not cause a problem. Final slide on shoes, footwear. What kind of shoes should you really be wearing?
Hello, Doc. We can't hear you. Apologies. Apologies, everyone. We're just trying to get Doc back on. Hello, Doc. Are you back?
Yeah, I'm back in. Sorry about that.
That's okay. Yeah, let's make you co-host so you can share your screen. Great. I think we're good to go.
Okay, so can you tell me where you lost me?
I think where you were talking about the food. Well, I mean, let's see. I mean, you had a slide up. Yeah.
You were talking about the shoes, the correct shoes to wear.
Okay. Right. Okay. So you actually didn't. That's fine. So the shoes have to fit you properly. They've got to support the foot, and that can change as to whether or not you're flat-footed or you've got a more normal type of foot shape with proper arches. Shoes that have laces are more accommodative, and also try to ensure that the toe box, which is the bit at the front, is wide enough to accept your foot. High heels are not really very good, but they're a fashion requirement, I guess. Trainers are incredibly good because they're designed for people who put their feet through extreme use. But they are not very practical for day-to-day use in the office, etc. But they are very well made and very well designed. There are a number of shops on the high street now which will do an analysis of your gait on video, and it's very instructive to go into one of these. They're usually running shops and walk on the treadmill and see how your foot hits the ground, and they tell you what type of support you need in a running type shoe. So that's quite an instructive thing to do. So I'll end here just with a few take-home messages to remind you that musculoskeletal pain is common. In the context of foot problems, you do need to choose shoes wisely. In the context of the African and Caribbean population, we have a different age profile from the rest of the indigenous population. We have different health demands as a result. And to compound that, we have a different health-seeking behavior because of our background. And in these areas, once again, I'll put it out there to CAHN to try to engage the community with the health services as we start to age and take on the same age profile, and therefore an increasing health requirement as the indigenous population. Once again, in these times of coronavirus, I thank the NHS, which I think is an incredibly good organization, and as we seem to be on the cusp of a second wave. Thank you. Can I stop sharing now?
Yes, indeed. We have loads of questions for you. Thanks, Doc. Okay. And then we can see your face. Let's get the spotlight on. So, Doc, if you can start your video so we can see you. Yes.
Yeah. Okay. Sorry about the technical problems.
No, that's fine. Hey, we're used to that. So the first question is, what is the cause of broken femur for a 32-year-old person who doesn't have any health issue?
So if you're 32 and you break your femur, you have a health issue, unless you've had you need a high energy injury at 32 to break your femur. You need to be involved in a car accident or fall from a height. If none of those apply, there is a health problem. There is a health problem. So if this is something where, let's say, you tell me you tripped coming downstairs, or you were out for a run and something happened, then you probably have brittle bones. It depends on where in the femur you have the fracture. There's a very small cohort of people who have fractures just under the hip. And that can be in young, very fit people who have the stress injury I described earlier on, where maybe you're in the military, or you're training for a marathon. You can have a stress fracture of the neck of the femur, the upper end of the femur. But if you're talking about the shaft of the femur, the thigh, you do have a health problem. Is there any further information on that? Anybody want to tell me a little bit more?
Can I speak? Because I'm the one that actually have.
Yeah, that's fine. I do.
Is that okay? Well, the pain only started when I had my first daughter. I'm on the phone. I'm not talking to you. So I just wanted to know what would have caused that, because it only we realized it was broken on the 25th of December 2018, and I was rushed to the hospital, and then that's when we realized I had a broken femur, but I never had any health issue before that. But
and you say this was, sorry, you say this was during pregnancy?
After I had my first daughter, yeah.
Okay.
Yeah. Well, I was having some slight pain. Then I went to the GP and said, oh, maybe it was because of my first child, and then just overlook it. Then the pain comes, then goes until 23rd of December 2018. Then I had, my leg just gave up, and that's when we knew there was something wrong. Okay. So it's not like I've been having the issue that, no, we're just on and off pain. And then the GP said everything was fine, and that was it.
Okay, if you don't mind, just one question I'll ask you. Did you have an operation?
Yes, I did. Yes.
Okay.
What's it called? at the orthopedic hospital in Wales.
Okay.
Yeah.
So it is quite uncommon. At times around pregnancy, you can have a condition called transient osteoporosis. But that usually is during pregnancy, and after pregnancy tends to resolve. And transient osteoporosis is when you have osteoporosis, which is thinning of the bones. It happens for a short period of time, and women of childbearing age around pregnancy. If it isn't recognized, but that's actually quite uncommon. If it isn't recognized, then can progress to a fracture, because the treatment at that time would usually be to advise you to have protected weight bearing for a period of time using crutches, etc. And so that goes into the category of what I would call a stress injury. I wouldn't put it down purely to transient osteoporosis. And if you're that young and you've had what is a low energy fracture, that is, you've had a fracture without having the usual level of trauma, then after the fracture has been treated by surgery, I think it's important to be investigated by people who have an interest in metabolic bone disease, and they'll just do a series of tests, things like vitamin D, calcium level, your thyroid function, etc., to ensure that that is all we're dealing with, a transient problem that then went on to end up as a fracture, rather than an underlying problem elsewhere. Does that make sense?
So if I may ask, yeah, it does. So is there anyone I can see just to take it further, because I don't want to risk it, and I'm hoping it's not transferable because of my kids as well. So
yeah, so I mean, at this stage, if it's 2018, I guess, you know, you've had the surgery, you've come over the surgery, etc. You do need to go to your GP and say, you know, I had this problem and I'm concerned. I don't know whether or not there's a predisposing factor. The GP may well be able to reassure you based on whatever clinic letters came from the hospital to say, oh yes, in June 2019, the doctor did say, I've looked at this, that, and that. Based on this test, this is what it is. Or they may not be able to give you any further information. If they can't give you further information, then you do need to ask for further investigation. So things like a bone density scan, the blood test I talked about, because you've had what is an injury to a major bone without the type of trauma you associate with ending up with that type of fracture.
Thanks, Doc. Is that okay, Adibimpe?
Yeah, that's fine. I'll have to speak to you later, so I know how to take it further from there, if that's possible.
Okay. Yeah, that's fine. I'm happy to.
That's fine. Thank you. Doc, the next question is, what can be done for an older woman who needs a knee replacement but is not mobile enough to do any physio afterwards?
Yeah, so that's a difficult situation, and we do see this occasionally, and that's where the process of consent and what are you needing from the knee replacement starts to come into question, and we take this into shared decision making with the patient. So what a knee replacement will do is that it will take the pain from an arthritic joint away. It's heavily dependent on physiotherapy afterwards. And you do need to be able to cooperate with the physiotherapist, rehabilitate the muscle, and also to do the movements that are required. Otherwise, knee replacement doesn't have a good outcome. There are a few things that can be done. If the reason the patient may not be able to cooperate with physiotherapy afterwards is maybe due to deconditioning, then you can have a period of what we call prehabilitation, where you have physiotherapy before you have the knee replacement. If it is due to factors, and I do see this in my practice, things like dementia, it's very difficult, because if a patient has dementia and doesn't understand why they should do exercises, which will be painful, then your chances of success are much less. And also think about whether there are other options or other treatment options, such as injections that can help with temporary pain relief. But I think it's fairly important to be able to cope with the physiotherapy, and you need a certain baseline degree of mobility. If your mobility is very poor, unrelated to the arthritis, if let's say you're only able to transfer from bed to chair, etc., then the utility of a knee replacement has to be discussed, because it's a major operation. You can have complications.
Thanks. And is any comeback on that, Teresa?
Yeah, I mean, it's I think it's age, and yeah, and she does have a bit of a mobility problem. So, I mean, the knee adds to it, and we took her to go and have it done. But when I said to the person, well, she's not very mobile, then they said, okay, well, this isn't for her because you need to do the physio afterwards. But then when she's in such pain, you're thinking, oh my God, what can we do next then? Because I mean, she's had injections. I mean, they work for a bit and then they stop. And now it's it's just making her mobility even worse now because of the knee.
So the reasons that I'll be interested in knowing is why the mobility is poor. And if it's purely due to the knee arthritis, then that's very easy. A knee replacement will deal with that. If there are other factors that affect the overall mobility, bearing in mind that the physiotherapy you need after a knee replacement is pretty much lying in bed, doing straight leg raises, bending the knee from 0 to 90, 0 to 100, and walking, initially with a frame. We'd expect you to progress to crutches, and would then expect you to progress to walking sticks. I think to have a knee replacement to remain comfortable in a wheelchair is probably not very good, because the knee replacement can end up being painful. And so what I would recommend is, if at all possible, she can improve her level of mobility with physiotherapy beforehand. And maybe there are other arthritic joints that can be dealt with, maybe hip replacements, maybe the other knee, things like that. But if at the end of the day the mobility is very poor, and she's maybe reliant on carers for personal hygiene on a day-to-day basis, then the recovery is a struggle.
All right, thank you very much.
You're welcome.
Thanks, Doc. The next question is, if someone has been recommended for knee replacement surgery and puts it off, can this affect other joints and their back?
Yes, it can. We know that, and I'll say that as a Black and Caribbean audience, we know that the number of people who are willing to have a major joint replacement, such as a hip and a knee replacement, is small. The percentage is small amongst our community. The Caucasian community are much more willing to have hip and knee replacements. If you put a knee replacement off, by and large, it doesn't affect your ability to have a knee replacement in the future. The arthritis doesn't go away. It's a permanent condition, and over time, it's likely to get slowly worse. If you don't have a knee replacement, then you don't use your leg to the same degree, and so your body will instinctively protect your knee. And that will place stress on the adjacent joints, your hip, your ankle, and also your lower back, and can cause pain in those areas. On its own, it doesn't induce arthritis in those joints, but can make the pain of walking worse. But there are things you can do if you're not keen on a knee replacement. Walking sticks, walking aids. We've mentioned injections, physiotherapy exercises. But at the end of the day, perhaps consider why you're not wanting to have a knee replacement.
Well, what is the recovery for a knee replacement? because I think sometimes people think, you know, taking time off work is a problem, so they're sort of a bit reluctant to go and have something done if it's going to mean a few weeks off work.
Yeah, so there's a significant recovery time. But the vast majority of patients who are having a knee replacement are not working. If patients come to me and they're still working and they want a knee replacement, I would have a long discussion as to whether it's the right time to proceed with a knee replacement. If you're so the average age of a knee replacement is just under 70, and by that time most people have stopped working. Some people will come in their mid-50s, late 50s, early 60s, and a few questions to ask: can you cope with it till retirement? For instance, if you've got two arthritic knees, then it's difficult if you're 58 to have a series of knee replacements and then retire at 61, because, you know, that's taking off, you know, most of your useful working life. In terms of the recovery, it takes about 3 months to go back to 90% of your full recovery, and about 12 months to get to your full recovery. But I mean, the outcomes are quite good. That's not to say that you can't get a complication. Nobody sets out with surgery to give a complication, but some people do get complications after hip or knee replacement surgery. But for those, the vast majority of them, 80 to 90% of them, who have a good outcome, it's a life transforming operation. But it's one that allows you go back to normal day-to-day walking, going up and down stairs, looking after yourself without pain. If you have a full-time job, especially if it's heavy, manual, repetitive, or you're on your feet all day, you will struggle with that job after a knee replacement. You will tend to struggle with your job after a knee replacement, especially if it's a full knee replacement. If it's a partial knee replacement, then the function tends to be better. And so if somebody is still working, I would have reservations. My youngest patient has been 33, so there's no bar to how old or how young you can be to have these knee replacements. But in terms of being compatible with a full-time job, then it's something you have to be aware of. If your job is sitting down at a desk all day, then that should be okay.
Okay. And finally, can I just ask, what is the difference between a partial replacement and a full replacement?
A partial replacement is where part of the joint is affected. So the knee, we think about it as having 3 compartments. There's the inner side, the outer side, and there's the part behind the kneecap. And any of those can be affected, or in combination. If you have 2 or more compartments affected, you will likely be offered a total knee replacement. If you have just one compartment affected, the inner part of the knee, the outer part of the knee, or the part behind the kneecap, then you can get away with the partial knee replacement. The most successful types of partial knee replacement are those that replace the inner half of the knee as opposed to the outer half of the knee. But only your surgeon will tell you if you're suitable for a partial knee replacement. And it's probably something to ask of your surgeon whether you're suitable for a partial knee replacement, because that is it's a less invasive operation. The implant is smaller and the recovery is quicker.
Thank you.
Thanks, Doc. Right. So there's a question about how people could be referred to a podiatrist. You know, does it have to be private, or could that happen on the NHS?
That happens on the NHS. That happens through your general practitioner, and the services are there. I think people who have diabetes and go for their diabetes checks are often aware that these foot services are available, because diabetic feet are a particular problem. A lot of other people aren't necessarily aware. So just like physiotherapy, a podiatrist or a chiropodist is available to most general practitioners. Also in hospital, if you get referred to hospital and the surgeon who sees you wants you to have an insole made for your shoe, then they will refer you to a podiatrist. So those are the two ways you can get to see one. You don't have to go private.
Thanks, Doc. I think, Vanessa, you have a question, if you can unmute yourself.
Hi there. Good morning, everyone. Just a quick question. What can a younger person do starting now to preserve bone health and prevent problems in the future? What can we do as practitioners to advise them?
Yeah, so the main issue with bone health is ensuring that you build up your bone density to a decent level before you start to lose it. And so your bone density starts to increase right from the time of birth. And that's just because you're growing. So your total bone mass will continue to increase. And that goes on till about the age of 30. And after that, everybody starts to lose bone. You can slow down the rate at which you lose bone, but you will lose bone after 30. So how soon your bone density will drop to below fracture risk depends on how much bone you build up before you're 30. Very difficult to build one after 30. So in the formative years, you need to concentrate on diet containing adequate calcium. And that's things like dairy products and spinach and where you can have fish that have bones, you can eat like sardines, things like that in your diet. And also vitamin D. Vitamin D is a problem in the UK because you can't make enough of it for most of the year. And in the summer months when you can, the black skin doesn't absorb enough of the UV rays you need to make vitamin D. So you probably need to take vitamin D supplements. Because of the whole issue with vitamin D, it is now fairly easy to get a vitamin D check because there seems to be a link with vitamin D levels and severity of COVID. So if you did go to your doctor for any health check now, you ask for a vitamin D test, it's fairly easy to get one. It used to be much more difficult. So that's the first thing, diet with enough calcium, and also making sure that your vitamin D levels are satisfactory. The second thing is challenging your bones whilst you're growing. Because if you sat down and did absolutely nothing, your bones don't feel the need to grow. So bones respond to the stimulus you put on them. And so the amount of weight-bearing activity and muscle strengthening activity. And for people under the age of 30, I think the minimum should be half an hour 3 times a week. And that gets you to a reasonably good amount of bone density by the age of your peak bone mass, about the age of 30, before you start to lose it. The other thing which I think you don't have much influence over this really is injury avoidance, because that's the other thing that hits your joints. If you have lots of sports injuries, then you run the risk of arthritis later on. A lot of professional footballers, by the time they retire, and we're talking about people between the ages of 35 and 40 retiring from professional football, have significant arthritis of their feet, ankles, and knees. So it's something to think about if you're not being paid the same amount of money as Lionel Messi or Ronaldo, but you're very, very passionate about your football or rugby.
Thank you. Thank you very much.
Any more questions for Doc? Dominique.
Hi, Doctor. Thank you for having us today. I have 2 or 3 questions. First of all, the first one is regarding shoe sizes. I know sometimes you mention about the shoes that we, especially women, we do wear kind of causes some of the pains that we do have. I've been advised that you always need to have one size up in terms of the shoes that you always try and buy, but depending on what size you are, it's not always easy, especially for big feet, to get, or people with a larger feet, especially for women, to get maybe if you're size 8 or 9 to get a bigger size. Is that true, first of all? Is that advisable for someone to always wear one size up? The second question that I do have is in regards to some of the pains that someone could actually have when they do exercises, or creepy, I could say, creaking noise. I'm asking the question personally because I sometimes do have this, I do exercise a lot, but sometimes I have this pain when I kind of walk, and you have that this creaking noise when you, with your knees, and it kind of worries me from time to time to know if is an issue that I should worry about, or is that normal?
Okay, so do you have 3 questions, or is it just those 2? I'll take them.
For now, yes, just those
Yeah.
2 things.
So in terms of your shoe size, you need to have the proper size rather than one size up. Your feet do fluctuate in size through the day, and they tend to be a little bit larger towards the end of the day, and there's a little bit of swelling then. So if you're going to have your shoe size measured, then that's probably the time to have it. Both feet are not always exactly the same size, and so you would always have the shoe that fits the bigger foot, but it's usually within half a size of each other. And you need to be able to just move your toes a little bit, have a little bit of space at the front end. And I think most decent shoe shops, I'll mention Clark's. Is it Clark's? I think it's Clark's. They do a decent fitting. Not all shoes come in the range of width that is required, and so that's something else to think about. If your foot is of a wider type, you might be advised to get one size up if you wanted to get a particular type of a particular shoe type. But generally speaking, if you have a shoe that fits you, there's no need to go one size up. You should stay in that size. If your shoe is too loose, you do end up with a different set of problems if your foot can move within the shoe, and you can get friction problems and blistering. In terms of exercise-associated pain, some degree of pain is normal or is expected after exercise. Pain that comes on after exercise, 24 to 48 hours after exercise in the muscles, which is called delayed onset muscle soreness, it is normal and happens when you're either starting a new type of activity or you've increased the activity which you normally do. And that is self-limiting. And as you get used to that activity, then it stops. Creaking noises in the joints are normal. They are expected, and we're not particularly concerned about them. Pain and creaking is not normal and does imply that there is an early degree of wear and tear changes in the joint. Now, if you do a lot of exercise, especially if it's impact activity, so things like running, badminton, tennis, or if you're running on hard surfaces, then you probably need the knees to be evaluated. What tends to happen is that there's a progression in many patients, not in your case particularly, from pain and discomfort on heavy activity to pain on light activity to pain at rest. And so that's what tends to happen. And you want to ensure that you're not getting any degeneration of the joint. If there's joint degeneration, then I think you'll get some advice as to whether or not it's time to start to modify your activity, or whether other health conditions mean that you actually sacrifice whatever joint problems you're having to maintain your physical fitness to stave off other health conditions. Because don't forget, I mean, it's a trade-off at times. If you did absolutely nothing, you would protect your joints, but then you'd have risk of heart disease and diabetes and all those other conditions which come within activity. Does that answer the questions?
Yes, it does. Thank you. Thank you very much.
Any other question? I think there was a private one about bunions.
Yeah, sorry.
So my aunt has bunions and are getting worse in growth and painful. Would you recommend surgery?
So it depends on the age, physical fitness, level of activity, etc. But yes, surgery has a place. If it's starting to become painful and you've tried a few of the supports, you've been assessed by a podiatrist, and you've ensured that the shoes are not, they have adequate space for the toes, then it's time to consider surgery. Depending on the age, if the toe itself is now painful, you may have arthritis in that joint, and you may be looking to have the toe fused, which gives you a good outcome, to be honest. And once again, I think the thing is to have the discussion, speak to the surgeon, accept that no surgery is risk-free, but the aim of surgery is never to leave you with a complication. Recovery from bunion surgery does take 3 to 6 months. The foot is swollen. You probably need to have protected weight bearing, and you have pain in the initial phases, but it's actually quite successful if in the right patient, where the other measures, the insoles, the shoe modification, etc., where those have been explored and you still have pain, then I wouldn't hesitate to consider surgery.
Great. Any follow back on that? Right. Great. So yes, I think another one, has come through also, but it will be good to get Doc your, reflection. Someone is asking whether you see more amputations in the Black community as a result of diabetes.
So that's a difficult one. Personally, we don't do amputations personally. The people who tend to do the most amputations are the vascular surgeons, and we send all the patients that need amputations to the vascular surgeons. In considering amputations, there are a few things that you have to think about, because the level of amputation, the suitability for prosthetics, what is going to happen afterwards. Are we hoping that you're going to have a prosthesis that allows you to walk and run, or is it one that's just for cosmesis? Those are all important and should be discussed before amputation. Yes, diabetes is one of the leading causes of lower limb amputations, but I don't have enough information, being that it's not a field that I tend to do, to tell you whether it is a particular problem or a greater problem within the Black community. I don't know, from personal experience and speaking to a number of patients who are newly diagnosed diabetics, that there's often some type of there's a reluctance to to accept the diagnosis, because most type 2 diabetes is potentially reversible. And because we know it's potentially reversible, we're usually much more willing to avoid medication and/or injections, and to try by dietary and/or other means. Because I think something like, I think bitter leaf has been touted as being having very good anti-diabetic properties. But whatever you're doing with your diabetes, ensure you're monitoring it, ensure that you're having regular blood glucose tests. And if whatever you're doing is working to control your blood sugar and your HbA1c level, then that's fine. If it isn't, then you probably need to have some medication as well.
Right. And Doc, the last one before you wrap up. Your views on pins and needles in bones. Is this something to be worried about?
So pins and needles usually affect the fingers and the toes. Am I getting that correctly?
Well, yeah, that's the questions. Yeah.
So when pins and needles, If they are persistent, then you should be concerned because they indicate a problem with a nerve, usually nerve entrapment or nerve degeneration. The commonest batch of people who have nerve degeneration are diabetics, and the treatment and or the prevention for that is to make sure that your diabetes control is satisfactory, because unfortunately, when the small nerves get damaged in diabetes, you can't really reverse it. In orthopedic surgery, we do see patients who have nerve compressions, and you can have nerve compression at the wrist, which causes pins and needles in your thumb, index, and middle fingers. You can have nerve compression at the elbow, and it causes pins and needles in your little finger, your ring finger. Or you can have nerve compression in the neck, which causes pins and needles in whichever place it's affected. You can also get the same kind of distribution in the feet. But if you do have it and it is sustained, especially if you're continually waking up at night with numbness, inability to feel an arm or a leg, then you do need to see your doctor. They will do some screening tests, ensure you don't have any vitamin deficiencies, examine you for any nerve compression, and then refer you accordingly to wherever you need to be seen.
Great, thanks, Doc. One more has come in. What is steroid-induced diabetes, and how can you get rid of it?
Well, steroids are very potent and very useful medicines, but they have a whole host of fairly significant side effects. So we try to avoid using steroids whenever we can. But I mean, when steroids are used, it's probably because nothing else is suitable. And in some patients, you will get diabetes as a side effect of the steroids. In that case, you can stop the steroids on advice of your doctor if alternative medication can be prescribed. The general advice for steroids is to use the shortest possible course and to use the lowest possible dose. And if those parameters don't suffice to control the diabetes, then unfortunately you do have to then start other measures to treat or control the diabetes, including the usual diet, exercise, and/or medication. But it is a recognized side effect of steroid medication in addition to water retention, weight gain, etc. But the reason the steroids are being taken is usually for a very valid and useful medical reason.
Great, thanks a lot. Well, another one has come in again. Do steroid creams also have side effects?
And I've just seen a follow-up saying for eczema, yes, they can do, depending on the, so steroid tablets or steroid injections go straight into your system. And if you're on steroid tablets or injections, the amount of steroids that you're getting is much higher. Steroid creams can be absorbed into the system, but at a much lower dose. And so it is very uncommon for steroid creams to give you the level of side effects that you have with systemic steroids, that is or indeed steroid injections. Those usually don't tend to cause problems relating to diabetes. But if you have severe eczema and the skin integrity is significantly affected, you can get enough systemic absorption, but it's very, very, very uncommon. It's very uncommon.
Great, thanks a lot, Doc. Before you say your final closing remarks, I think your good friend from Canada is on the call. So I'm going to put the spotlight on Annie to say a few words. And as she will tell us her specialty, but, we hope to have her one of these mornings. So, Doc, we're really grateful to yourself, to Ngozi, to Eddie, and many others for the time you keep giving. I'm sure if you were charging us, we wouldn't, be able to do that. But over to you, Annie, for a few words all the way from Ontario, Canada, before Doc finishes up.
Thank you. Hi, thank you so much for a very, very useful, very practical talk. We're so proud of you. We're your classmates. So I'm in from Canada. It's just about 7 o'clock. So it's really well worth it. Thank you. We're very proud of you. Thank you. So I'm a pediatrician and unitologist here. Thank you.
Thanks, Annie, and we're really grateful for your, compliments and coming along to support, Doc. So over to you back, Doc, for your final, remarks.
So
before we see you again in the next few weeks.
So once again, I want to thank CAHN for this series of health hours that you're putting together, because I think it is very, very useful for it's a very useful service to the community, and thanks for giving us doctors the opportunity to interface, because you can practice for very long in this country and not realize that actually you're not treating a lot of Black patients, and you wonder why, and you just assume perhaps that they don't have those problems. Well, looking a little bit deeper into it, and also having spoken to people, there is some anxiety around questioning the system when you don't think you're getting where you're supposed to be getting. And the same level of anxiety doesn't by and large replicate itself in our Caucasian population. So I think really what you're doing is very empowering. And I would encourage you to get involved, and I'm sure you are, with addressing the health inequalities which we have, and bringing the health service, more in tune with Blacks. And just one final thing, ethnic minorities and Blacks, maybe not quite the same thing, because a lot of work on ethnic minorities relates to South Asians in this country, who historically have been a lot more engaged. And I think if you go to hospitals, you see lots of signs or leaflets in Urdu, Gujarati, Punjabi, etc. And it tells you the level of engagement which has taken place. And I think CAHN probably has a good role to play in this type of activities. Well, once again, thank you very much for giving me the opportunity, and thanks for all those who have dialed into this call.
So, Dr. Theophilus Asumu, we once again really grateful for your time, and there have been a follow-up, a couple of requests, to contact you privately, which you accepted in the past. We're really grateful, and with regards to the addressing health inequalities, we're really grateful for your support and that of your colleagues. We're just about to have a final consultation with leads within Greater Manchester Health and Social Care Partnership to develop a program for primary care. So this will replicate what happens when it comes to pride in practice and all the awareness. So this will be focused on the Black, Caribbean, and African community. And we're really excited and delighted for that. And we have, we've asked a couple of GPs, as well as we'll be speaking to Ngozi, to come along to a session where they engage clinician to clinician and, really put their weight behind this. And we hope that will bring a fundamental shift in the poorer outcomes for, our community. So Dr. Asumu, once again, you were really grateful for your time and that of your other colleagues. We're hoping to do some real acknowledgement and recognition during October when we celebrate Black History Month, because you guys are making history, giving lots of hours that we couldn't have paid privately for. So we're very grateful. And welcome, Annie. We will discuss further, since you are Doc's friend, and we will keep using all the networks and, friends and contacts. So to everyone who has been on the call, CAHN is for the community. It's been driven by, what is important to you as a community and to all of us. So if you want to volunteer, if you have any ideas, any feedback on the way we do things, you have any creative, ideas, please feel free. We're all accessible, and together we will make a difference in our community. So I'm sure very soon, we're going to have Dr. Adio Sagi back, on gynecology stuff, because Ngozi is on there and she's agreed to that. So thanks everyone. Enjoy the rest of the weekend and keep safe. Make sure you protect yourself. We all know COVID-19 is still with us. So let's protect ourselves and, let's look after one another. Thanks, everyone, and bye. Doc, we're grateful once again.
Thanks, Theo.
Stay safe, everyone. Thanks, Anne. Take care.
Thank you.
Thank you.
Thanks, Doc. Thanks, Reverend Charles.
Thanks.
Bye.
Bye now.